Good afternoon. Thanks for being with us. On behalf of the School of Public Health here at Georgia State, I'm pleased to welcome you to the 2025 John R. Lutzker Lecture Series. We have a total of 163 registrants, and many of you are here in person, the rest online, so a really great response. I'm really delighted to welcome you, and also that you're here to honor our distinguished Professor Emeritus John Lutzker, the former and founding dean, director of the Mark Chaffin Centers for Healthy Development here in the School of Public Health. For those who can't be here today, we're also going to be recording this to view later. I just want to say a bit about Dr. Lutzker's contributions. His contributions have really been invaluable. He dedicated his entire academic career to advancing scholarship in the service of preventing child neglect, and is an internationally recognized expert in the field of child maltreatment. He's responsible for developing one of the few evidence-based child neglect prevention programs, Safe Care, implemented throughout the United States and internationally. His efforts have really elevated the Mark Chaffin Centers for Healthy Development to a university research center that is committed to preventing and addressing child development delays, child maltreatment, and sexual assault. It also facilitates social emotional development and well-being and promotes meaningful inclusion and quality of life for individuals with intellectual and developmental disabilities. This lecture series is funded by an anonymous donor and allows the School of Public Health to host an eminent scholar selected each year by a national peer advisory board to present on a public health topic. At this time, I want to invite Dr. Kathleen Baguette, Director of the Mark Chaffin Centers for Healthy Development, to introduce this year's speaker. Please welcome her.
Well, good afternoon. It's a delight to be here with you today to introduce this year's Lutzker Lecturer, Dr. Eric Bruns. Eric is a professor of psychiatry at the University of Washington Medical School, and he's the associate director of the SMART Center, the School Mental Health Assessment Research and Training Center. He's internationally known for his research on school mental health, care coordination for youth with complex needs, and the application of human-centered design and implementation science to youth behavioral health programming. He's engaged in multiple leadership roles. His efforts through the School Mental Health International Leadership Exchange focus on improving student outcomes, and his work with the National Wraparound Implementation Center is a model for addressing and advancing youth mental health. Within the University of Connecticut Innovations Institute, he's advised numerous states and communities on their systems-level policy and finance structure. He's trained as a clinical and community psychologist, and he is heavily invested in expanding the research base on these topics to support decision-making to support youth mental health. Eric's work in the area of implementation science, and not just in the area of models, but in actual strategies and technologies, his focus on human-centered design are truly noteworthy. So his work embodies the spirit of this lecture series, which is to advance understanding of solutions for addressing complex public health challenges to improve the quality of life for youth and their families. So I could spend a lot of time up here talking about his many accomplishments, but I think you will find him engaging storyteller of his own journey. And so I'll turn it over to him. Please welcome Dr. Eric Bruns.
Okay. Good afternoon. How's everyone doing? All right, all right. Well, thanks so much, Kathleen and Rodney, for those introductions. It is truly a pleasure to be with you today. Kathleen arranged a lunch this afternoon with faculty, postdocs, and scholars from the centers, and it confirmed 100% that we are kindred spirits in terms of seeking solutions to improve the lives of youth and families and trying to apply our best evidence to those solutions. Folks at the Chaffin Centers are clearly my kind of people. So I am a little nervous about being here today. I looked at the speaker list that have been here at this annual lecture series. You know, at our Seattle Children's, where our child psychiatry division is, we have a monthly lecture series to be selected to be the annual speaker, along with folks like Greg Ahrens, who I'm going to be referencing his work many times today, pioneering implementation scientist. And then just last year, my very, very good friend Shannon Dorsey was here, I believe. She's a brilliant researcher, shares my quest to get EBPs, evidence-based practices, done by as many types of folks as possible, herself in low and middle-income countries, myself in schools. One of my greatest accomplishments, I would say, professionally, is luring Shannon to the University of Washington in 2006. And of course, Mark Chaffin was just an incredible scholar and person whose life ended far too early. So I hope to be able to live up to the legacy of all of these great folks who precede me and after whom your different centers are named. So as Kathleen noted, I'm a clinical psychologist by training, but from day one of my career, I've been really focused on the question of how to achieve population impact for youth and families. And so I have done this with individual level models, such as brief school mental health interventions that we hope will fit better into the school context. Bringing innovations from clinics into schools requires a lot of tailoring and a lot of redesign. Wraparound care coordination is another thing that I have been known for and spent 20 plus years of my life working on. I was a care coordinator when I was a young person just out of college and said, you know, this would be a great thing to actually spend a career working on, and it's been a career. But more and more, again, focusing on how do we mobilize the evidence for all that we have, all the evidence we have for what works for youth and families to build robust systems of care that can meet the full pyramid of needs that youth and families have, and a true public health model, and how to best shape policies and funding drivers that are going to allow that to happen, allow these practices to be taken up at scale. Now, you all don't need to be reminded of this, but unfortunately, the need is greater than ever, more urgent every day, because somehow, despite all of our many innovations, the need just keeps getting greater. And we used to refer to a pyramid of need that talked about how, you know, we try to prevent mental health problems in 80% of our kids and seeks interventions to treat the 20%, but with symptoms of depression and diagnoses of depression skyrocketing in our kids, we're no longer talking about how to prevent problems in 80%, but we're now talking about trying to figure out how to support more like 40%, as opposed to the old pyramid where we would talk about 20% of all kids. So today what I'm going to do is provide some broad claims about what we need to be working on with respect to implementation science, design thinking, and policy research, with some examples from those centers that I work with, and thanks Kathleen for referencing some of them. We're all encouraged to have an elevator speech in our careers to try to explain to people what we actually do when it's a little wonky, right? So I kind of like to make the audacious claim that I've, you know, founded a lot of centers, but two of them, one of them, the School Mental Health Assessment Research and Training Center, the SMART Center, here we're trying to provide supports, social emotional learning programs, tier 1 and 2 supports to support that 80%. And then we have the National Wraparound Implementation Center, which is in 20 plus states, training and coaching professionals to provide care coordination to that small percent of youth who experience the worst outcomes, but for whom we spend the vast majority of our available mental health dollars because of often unavoidable residential and congregate care placements, that if we invested those dollars in upstream programming and care coordination to help families do whatever it takes to keep their kids at home, we would be able to actually apply our resources more across the whole pyramid. And then finally, we'll be talking a little bit about our UW, University of Washington Alacrity Center, which is an NIMH-funded P50 center, now in its second round of funding, and the University of Connecticut's Innovations Institute. The Alacrity Center is asking, how can we apply lessons learned from implementation science broadly to promote uptake of evidence-based practices? And our Innovations Institute is out there doing policy, training, and coaching work in multiple states to try to get implementation science done. So this is just a little bit of where I'm going to be pulling some of the kind of specific examples from my work. So it's always fun to show some pictures of your teams. So the SMART Center just had its 10-year anniversary. This is just a small number of our 40 folks. Let's see what else we have here. Here's the beautiful campus of the University of Washington and our wraparound research lab there in Seattle. Let's see, what else do we got? Oh yeah, here's the Innovations Institute folks in their new home in Hartford, Connecticut. And then this is a picture I really like. This is a reception we had at our training institutes in Washington, D.C. And I like to, this is 50, 60 folks who are doing wraparound in states all across the country who use our fidelity measures. And I like to show this picture because they're fun, but this last one, it also makes a really big point about implementation that we were actually talking about in our lunch earlier today. This is what I threw into the slides afterwards, right? Which is that, so the Chaffin Centers are all about being national centers of excellence around various models to prevent maltreatment and promote other kinds of positive outcomes. And so what's interesting is if, so they're in the business of being a government academic kind of center of excellence, as is our Innovations Institute. And so if you map all the research to policy engagement initiatives out there, there's a group called Transforming Evidence in the UK that I just love. You should look them up. It's incredibly useful and digestible stuff. Catherine Oliver, they mapped all of the different ways in which academics try to support policymaking and governments out there. And they characterized hundreds of different strategies into 9 types of research to policy work and 3 big categories. Linear, which is kind of a push-pull model, relational approaches, and systems-level approaches. And the best available evidence that they found from a massive literature review of all those different types of public academic partnerships is that there is so much better evidence for the relational approach than any other model of working as a center of excellence with the public than any of the other strategies out there. So that's where I like to kind of emphasize how we, in our SMART Center and our national wraparound work, we're always trying to build these long-term relationships with folks in states, with folks all over the country who are implementing our models. This is the way stuff gets done out there. And if you're a center of excellence, it's something that is invaluable to be able to try to build infrastructure to do. Okay, so that might have been a really important point, but here's what we're going to actually cover in the talk. I think from our research on school mental health, community interventions, you all know that we've got robust evidence for mental health strategies and what works, but somehow only 20% of young people get the care that they need. So we have to turn to how do we get those things actually done out there in the real world. So implementation science is one of those things. Implementation in the real world is a multi-level endeavor, so we'll talk about strategies the SMART Centers use at each level. Interventions and implementation strategies themselves really could be better designed to be more effective, and so we'll talk a little bit about that. And then finally, apropos of the center of excellence kind of question of how can we have the most impact, the outer setting of the implementation ecology, those policy, finance, knowledge transfer kinds of strategies must be leveraged, and we really must be doing more research on those as well. Quick acknowledgments of funding. A lot of it comes from the Institute of Education Sciences, National Institute of Mental Health, the IES funding. We're hoping there will be a time when research, education research, and other research is a priority of our federal government again. In the meantime, a lot of our team's work is now being supported by those contracts with states and provider agencies and schools and districts to get this stuff out there. So that's another benefit of those long-term kind of relationships for academics, another motivation for us. This is a picture of Aaron Lyon. He was once a mentee, and now I'm his mentee. He is the PI in a lot of our Smart Center grants. He is an implementation scientist to the core and a true genius. It's always cool to have a mentee who, provides you salary support into your dotage. So we should all be striving for. All right, so the Smart Center, School Mental Health Assessment Research Training Center, med school, social work, and the College of Education. As we were talking about earlier today, it's not an easy thing to pull off, but we've done a lot of research, right? So we have confirmed that something that's been stated a lot in our field, which is that schools, along with outpatient clinics, are the most common venue in which youth receive mental health care. We also have done studies asking what are the top problems that students come to school mental health for. What do you think the answer is? What's the number one reason that students come to a mental health clinician in school? Anxiety, depression. What was that? Bullying, right? Social media, body image. It's actually academics, by far. Right? The number one reason they go to clinicians in schools is because they're having a hard time getting their homework done, getting their graduation credits, or whatever. So we have to recognize that in our school mental health strategies. It's the number one place in which kids get help, and their number one need is actually school-based. So we have to figure out how to adapt things that are in our clinics to that actual reality, right? What else have we done? We've indeed developed then brief interventions that are fit to the schools that kind of address those kinds of needs. And most recently, Shannon, my friend Shannon Dorsey, if you were here last year, she shares this quest with me, which is we're asking how do we get evidence-based practices done in real-world schools by paraprofessionals who are not licensed clinicians. This is going to be the only way we get this stuff really scaled up in schools, and that it's not just focused on treatment, but also prevention and early intervention. So we've been working on all of these things. This is just a little snapshot from what is soon to be my most often cited paper, which is the meta-analysis confirming that schools are the most common venue in which youth receive mental health care, but essentially tied with outpatient settings, both for general population samples, as well as youth with existing diagnoses or existing symptoms. Schools are the most common venue we found from this big meta-analysis that we did. So it's clear that schools play a major role in promoting the emotional wellness of our children. Not only is it the most common venue, we find robust effects in meta-analyses, such as found by Amanda Sanchez and crew, both for school mental health targeted interventions and selective prevention programs. We know that social emotional tier 1 universal learning programs can improve not just behavior and students' wellness and coping skills, but perhaps most importantly to the schools, 13% increase on average in academics performance if you implement social emotional learning and do it well. That's the important thing. You have to actually implement it to the model. Positive school climate protects youth from external risk factors. And not only are schools the most common venue for mental health in general, it is the place where disproportionately low-income youth, youth of color, who might otherwise have barriers to accessing care in places like mental health clinics, they are disproportionately represented in the services that are provided in schools. So school mental health improves access for youth who would otherwise not receive mental health care. The issue here for us at the Smart Center and all of us is that school-based services really could be improved. The majority of attempts to implement EBPs in schools are unsuccessful. When implemented partially or without fidelity, those SEL program effects become null. When you talk to folks like school psychologists, they say they rarely or never use behavioral evidence-based practices. And so, the director of the Institute of Education Sciences himself, Mark Schneider, very interesting guy, he says there is this persistent last mile problem in education research that we have to address. So let's talk here about how implementation science attempts to address those problems. And this is going to be a lot of examples from school mental health, but most of the implementation strategies and solutions I'm going to talk about are derived from and relevant for mental health, healthcare, and other kinds of settings as well. Okay, so clearly the Chaffin Centers are no stranger to implementation science, but here's one commonly used definition: the scientific study of methods to promote the uptake of research findings and other evidence-based practices into routine practice. And, you know, more important, we have to meet our quota of Dilbert cartoons. So here's implementation science according to Dilbert's coworker. I'm back from training. I got a big binder. The training is already forgotten, but the binder will last forever. A living monument to temporary knowledge. How many of you have such a monument on your shelf somewhere, right? We've all been to training. There was no follow-up. There was no trying to get you motivated to use it before training. There was no support to use it afterwards. Your supervisors didn't really care, and so the binder's still on your shelf. That's what we're trying to avoid, and there are systematic strategies to do so. But we want to make sure that in explaining implementation science, when we try to convince folks of this, we use plain language. So I love Jeff Curran's Implementation Science Made Too Simple paper. He says, this is how you explain it. The innovation, the program or strategy, that's the thing. Effectiveness research, that looks at whether the thing works. But implementation research asks, how do we help people do the thing? Implementation strategies are the stuff we do to help people do the thing. And then finally, implementation outcomes are how well and how much do people actually do the thing. All right? So just remember that. We can explain things that way and it'll be totally fine. But we want to move to Implementation Science 201. What this tells us is we don't want to jump to those strategies, implementation strategies, too quickly. So as we look at implementation building blocks, at the lunch meeting this morning, someone said, like, well, how do you make implementation science actually work to get these programs done? The first thing you can do is just put on this implementation headset, right? Is to know that for every program you're trying to get done, there are determinants, things that facilitate or inhibit practice uptake or change across multiple levels that we have to identify. Once we've identified those determinants, I'll make a little box show up here, then we can move to the strategies. We don't want to jump to strategies too quickly. That'd be like, you know, a recipe that's just ingredients without an actual, you know, set of steps that we would use to figure out how to use those ingredients. So it's important to consider those determinants before we decide what stuff we will do with who to do the thing. So strategies might be, you know, training or coaching or develop stakeholder relationships, get thought leaders or opinion leaders in the place to actually be motivated to share their experiences with their peers, right? All sorts of implementation strategies out there. Methods or techniques to enhance the adoption of a program. So you say, well, gosh, which strategy might I use once I've come up with, you know, my list of determinants, things that might get in the way of my program getting done, or maybe things that'll facilitate it getting done. This is when we can turn to Byron Powell's really cool work identifying and then characterizing and taxonomizing, if that's a word, implementation strategies. So it's called the Expert Recommendations for Implementing Change Project, or ERIC project, not named after me. It is an acronym. But it's the most comprehensive effort to identify implementation strategies in healthcare. And so it was originally 73 implementation strategies. I think it's grown. But then Byron and team did a concept mapping, which is a really cool statistical technique, to say how do these 73 strategies we've identified hold together. And so then they were able to create a taxonomy of them, such as engage consumers, which in this case would be the practitioners, right? Develop stakeholder interrelationships. Utilize financial strategies. Maybe we will have a pay-for-performance kind of strategy. support clinicians, so perhaps through coaching or better supervision. So the ERIC compilation provides this common language for us to both conduct research and have there be some kind of harmonizing of what we've learned about what gets things done out there, as well as help purveyors, centers of excellence, kind of say, all right, what are some ideas about how we might, address some of these barriers or facilitators. Now, what's really cool is that then my buddy Aaron and my buddy Clay Cook and others, they took the ERIC strategies and they created the sister project, School Implementation Strategies, Translating ERIC Resources. It's one of our favorite kinds of acronyms at the Smart Center, the acronym that has an acronym in the acronym, right? That's when you really know you're onto something. So the sister project took the ERIC strategies and then translated them into the school context, and then asked a whole bunch of educators and school mental health clinicians, which of these have you seen to be helpful and useful? Which ones are actually doable? Which ones are feasible? And it comes up, so the ERIC and sister strategies, this is really cool, not just because it gives me an excuse to show a picture of me and my sister, but because what we learned is that if you map the importance and feasibility of these 75, I think we're up to now, sister strategies, we see this linear relationship where the more important the strategy is, generally the more feasible it is. So that's really good to know. And it's also good to know what we think might be important and what might be feasible. So let's look at our plot here. For example, make training dynamic. Theoretically, this is somewhat feasible, although, sometimes we also just talk to people like this. But this is an example of an implementation strategy. Make your training more dynamic. A little bit, just as important, but, just as feasible, but maybe a little bit less important than making your training dynamic, distribute educational materials, another example. Another example in the go zone. So if you know what a go zone is in one of these charts, it's the plot, part of the quadrant of the plot where you're both feasible and important. That's where you want to focus, right? So another one in the go zone is conduct ongoing training. So not just one and done, but actually provide reinforcers and boosters. What are some things in the no-go zone? Change accreditation or membership requirements. Not likely to happen very easily in schools. Create or change credentialing or professional development standards. Change school or community site. So we're just going to pick up and do it somewhere else. These were things that fell in the no-go zone. But anyways, just some examples of implementation strategies in schools. And these are just examples of things that we can do to go from letting something happen, just trying to let a program get done, to actually making it happen. Moving from diffusion, which is basically just like me telling Kathleen about a cool program and how to get it done, to dissemination, which is more targeted information sharing, to implementation, which is actually use of these strategies in a really purposeful way to get evidence-based practices done. So yeah, moving from letting it happen to making it happen. Okay, so let's dive into some examples of things that we need, the different levels at which we would apply these strategies. So again, strategies are just, ingredients in the recipe. We need an actual process of thinking about how we're going to deploy these ingredients and actually use them. So this is the Consolidated Framework for Implementation Research, the CFIR. How many folks here have ever heard of the CFIR, the Consolidated Framework for Implementation Research? Yeah, so it's getting out there, right? It's been 15 years or so. The thing is, and so this provides clarity for considering the kinds of things you need to work with at multiple levels of the implementation ecology. And that includes the characteristics of the individuals that would have to actually mobilize your program or your innovation, the inner setting, which is the organizational level, the outer setting, which is the policy, finance, kind of broader community level. And then there's this often neglected driver, which is the intervention itself. So this provides clarity and helps us both do research and plan our work trying to get something done. Now, the fact of the matter is that the CFIR was one of the first ones, but now we've got hundreds, I think it's probably more like 300 or 400, implementation science conceptual frameworks out there. which gives me the opportunity to tell our favorite implementation science joke, which is how are frameworks like toothbrushes? Stop me if you've heard this one. Because everybody has one, and no one wants to use anybody else's. That's how implementation science frameworks are like toothbrushes. Okay, so let's talk about these levels briefly, and because all of our examples are going to be at one of these levels. So there's the outer setting level. In schools, this could include the academic calendar, which clinic-based interventions are not going to be designed thinking one bit about. All right? There's policies around who's actually allowed to provide services in schools. What are the laws that govern them? FERPA versus HIPAA, for example. District policies about whether or not there's a real centralized governance or if each building is allowed to make its own decisions. Then at the inner setting, we're talking about school buildings. So leadership is really critical at the inner setting or the organizational level. We're talking about principals, but we also might be talking about the heads of school counseling. We might be talking about the school improvement team. Other things that are in the inner setting or the organizational level. The extent to which people in the schools actually have expertise. Do they know anything about SEL programs and how they work? Do they understand mental health interventions? Let's see. Oops, forgot to animate. So turnover rates. And of course, schools have different levels of resources. Implementation people might be like, do they have a resource to do follow-up coaching? But it might be more like, do they have the resource to even refer to a single mental health provider that serves kids in your community, right? Or do you have one school counselor for 1,000 kids? So level of resources is something that you have to take into account as a possible implementation determinant. And then at the individual level, we're not just talking about the educators or the professionals, but the students themselves. In schools, we just heard that academic problems are the #1 problem they're seeking help for. That's probably not something that a clinic-based, evidence-based practice is thinking about. Another thing that's specific to kids in schools is that we have to ask, how are we going to have multi-level interventions? Because a lot of times kids just pop into school counselors' offices. They're not coming with a defined symptom. So we have to design around the needs of both the professionals that are doing the work and the students themselves. And then finally, the intervention characteristics. Programs, again, that have been ported into schools from clinics might not take any of those previous things into account. And then there's the fact that researchers, it turns out, are really not very good at designing things to be usable and appealing. They might be able to design things to get good outcomes in a really controlled research trial, but something that's going to actually be appealing, commercializable, scalable, not so much their thing. And yet this is kind of a forgotten element of the implementation science kind of ecology. So yeah, again, I think I covered all these things. All right. So let's talk about design problems, and then we'll give you some examples. What are some of the design issues in school-based or other kinds of interventions? Well, we've got over-design, we've got under-design, and then, of course, there's just bad design, which is like also the now thankfully near-defunct USB things. Is there any way you ever do it just once and get it right the first time? Like, who designed that? So luckily, our USB-Cs have overcome this, right? So what's interesting is for school mental health, interventions and programs are both over and under-designed. They're over-designed to succeed in the efficacy research, which is what the researcher's really interested in getting done, but under-designed to actually be flexible and multi-level and all the things that might make it useful in a place like a school, right? They're usually complicated and infeasible, require replacement of existing practices, and yet they're under-designed because they're not designed to accommodate the presence of other kinds of supports like tutoring and academic support, and so on and so forth. So we have to bring human-centered design to this process as well as implementation science. And it's more than just testing out what people think of your new digital intervention. Ideally, in human-centered design, we're starting by understanding the need before we plan our human-centered design process. So you start with planning, understand the need, Specify the users. Make sure you know who you're actually designing for. Oftentimes people will jump to solutions without thinking about who's actually going to use this thing and what are the constraints on their lives, their professional lives or other kinds of lives. Then you develop the design solution. Make sure you do it with users. Iterate several times with testing, measuring, learning, and when and only when the design meets the user context and requirements, ideally are we scaling these things up. So human-centered design and implementation science luckily have complementary objectives. So implementation science, all that stuff I was talking about before, they're usually trying to change the setting in which we're putting a program while maintaining the program's fidelity. Human-centered design is the flip. So human-centered design is trying to change the program or the innovation to be more usable, but not change the setting. So if you bring human-centered design and implementation science together, we can hopefully get to better innovations that are, iteratively solving real-world problems. Bring the implementation science headset and some human-centered design together. So let's take a look at an example of one of those at the inner setting, the organizational level. So I'm going to walk through a few examples from the Smart Center here, and that draw from both design thinking and implementation science. So we'll start with the organizational context. So remember, this is the school level. This is where leadership and climate are really key to getting things done. And so, recognizing this, the Smart Center decided to ask, how can we apply human-centered design and implementation science to the cause of helping education leaders mobilize evidence? And so that led to a very, very lovely acronym, HELM, which you can have like all sorts of kind of ship themes and things like that I won't bore you with. But this is adapting Greg Aaron's LOCI model, the Leadership and Organizational Change for Implementation model, which was designed for healthcare, and we're bringing it into schools. So like LOCI, HELM is again organizationally focused, talking about school level, focused on leaders like principals. And so HELM has several components over here. So interactive training, including an overview of what does it take to be a good implementation leader. We then give feedback to the leader, feedback reports from survey data from their own staff on their perceptions of whether or not their implementation climate is a positive one, so that provides the foundational kind of information for a leadership development plan to get this thing done in the school. And through regular meetings with coaches, the principal or other leader tracks their progress on how well they're doing on those goals that they develop and those plans that they develop. So the idea here is to both improve the principal or other leaders' implementation leadership, as well as the overall climate of the school for taking up this innovation. And what we're hoping is that will lead to better fidelity, implementation of the program, maybe positive behavior supports, maybe something as simple as we have tested HELM with as positive greetings at the door. One of the most impactful, kind of amazing strategies you can use to improve behavior is simply having every teacher greet the students at the door. And yet it's hard to get teachers to do it. So that was one of the actual interventions that we've used in testing HELM. And eventually we will get to those behavioral and education outcomes. So to develop HELM, we went through a number of, and this was really Aaron and his team, went through a number of stages or phases, including, my little arrow showing up, oh no it's not, I'm doing that for no reason, including a usability evaluation. So again, bringing implementation science and human-centered design together. So there were findings from a couple of different trials that HELM is associated with higher implementation leadership, better implementation climate, and some new research that's suggesting it's also getting to better implementation of the actual innovation. But I'm not going to talk about that. I'm going to talk about the usability evaluation, because this is actually where the human-centered design and the ImpSci come together. So we were talking about this earlier with Anne-Marie. So it reinforced that this is maybe not too wonky or not useful. How did we do this phase 3 method of asking, is Helm going to be designed for success? The Alacrity Center and Smart Center worked together to create something called cognitive walkthroughs for implementation strategies. So the CWIS, or Swiss, depending on how you like to pronounce it. Aaron says CWIS, so that's what I'll say. This is a way to systematically develop an implementation strategy like Helm to get the thing done. So the first CWIS step is to determine preconditions. So what needs to be in place for a strategy like the training or the coaching or reminders or the different pieces of Helm to actually be successful. You also identify user groups. Who is this actually intended to affect? And so for Helm, this was both the principals and those coaches who were going to go out there and do the work. So we had to say, what are those preconditions for those kinds of individuals? And we decided that coaches needed to themselves have been leaders in schools if they were going to be successful. And we said principals needed to be principals for at least 1 year before they would be likely to take Helm up. So quickly, then we say, okay, what is this implementation strategy? What does it entail? So you list out all the tasks that this supposed great idea you have is going to consist of. And you rate them in terms of how likely is this task going to provide a problem? And how big of a problem would it be if it didn't get done? So likelihood of a problem and criticality of correct completion. From there, there's task prioritization. So then you take those tasks and you use them to build scenarios that you're going to then bring into group testing with users, so principals and coaches, and you walk through scenarios that have been built around those tasks, prioritizing the tasks that you believe are going to be the most difficult or the most problematic. And it's only by doing that, you don't jump to implementing this thing. If you do this kind of work, this is human-centered design thinking applied to implementation science, right? Pretty meta. But, and I have to admit, when it was all being dreamed up, I was like, this is totally ridiculous, you guys. Like, this is way too much. You're overthinking this stuff. There's no way people are going to do this. 5-6 years later, we have used this CWIS strategy many, many times, and we're always grateful for it. It is saving you so much time and heartache in the long run to do something systematic like this in the front end of developing something. The other things that we were talking about this morning that it does, for those of you who are students or junior faculty or anybody, is it gives you something you can write about in a paper before you even implement the thing. You can describe what you learned about the tasks, about the feedback in a systematic way from the users, and how you did redesign solutions to deal with the problems that arose. So examples from Helm, there were easy fixes, like we learned that the volume of 360 feedback reports was just too much. It was like hard to find stuff in our reports. It's like, we'll put hyperlinks in the tables of contents. Turned out that was actually good enough to help them with that problem. Then there were things that were a little bit more challenging, like coaches' lack of knowledge about how school building climate impacts their ability to coach. So the solution here was to co-design the coaching model with former principals and incorporate in-person touch points between the coaches and the principals. Okay, so we'll just finish up this example. In addition to identifying the barriers and solutions, which again you can write about, you can put CWIS in your grant proposal instead of just waving your hands around and saying, yes, we'll design the thing with input from multiple stakeholders. You can show all these things that you're going to do with them. And reviewer says, oh, that looks good. And actually, gives you a good score on your method section. But so one of the things that you do in human-centered design is you also do quantitative ratings of the usability of the thing. And there's a tool that's widely used in digital products called the System Usability Scale, or SUS, that actually has benchmarks for what a good score is, saying you can go ahead with this or you should get back to the drawing board. And so we adapted it to create the implementation strategy usability scale. And we found that the coaches and the principals at the end of the Helm iterative development process said, this is good enough to move forward with. It scored in the excellent range. The coaches gave a little bit better score. Let's see, how are we doing on time? We got about 5 or 6 minutes. So let's do a couple more examples. Individual level example from the SMART Center. So at the individual level, trying to get things done means we need to interact with motivation, right? Motivation and ease of use to actually get the thing done. And when it comes to school staff in particular, time is the thing we always hear. I don't have time for this. My day is just way too busy. I have too many responsibilities. Most commonly identified implementation barrier. One of our clinicians in one of our groups said, if it's worth my time, I'll make the time. And so at the individual level, we have an implementation strategy called BASIS, yet another fantastic acronym. Beliefs and Attitudes for Successful Implementation in Schools. So BASIS is based on 2 major theories. Theory of planned behavior, which states that attitudes, social norms, and self-efficacy are the drivers of intentions and behavior. And a health action process approach. So I'm going to quickly just kind of not go into too much depth here, but so there's motivational components and volitional components to this pre and post-training little booster that's focused not on the intervention, but on motivating folks to actually use the intervention. So they're doing things like, doing a training, again, not on the intervention, but on ways in which the intervention actually is likely to benefit their students, or maybe their lives. Motivational interviewing is actually built in there as well. And we identify who are the people who are likely to influence folks' behavior and try to prop them up to promote better implementation climate. So this is intended to affect attitudes and self-efficacy. Both the volitional and motivational components of this little BASIS training are intended to get to implementation intention as well as self-efficacy and get to those implementation outcomes, which tells us whether the thing is getting done. Did trauma-focused CBT get adopted? Did it get adopted with fidelity? Was it sustained? And so let's skip through this really quick. There are 2 different flavors of BASIS. We've developed it for educators as well as for mental health clinicians working in schools. It's been tested. It's been used with CBITS, Good Behavior Game, TFCBT, Positive Greeting at the Door. And the bottom line is that the findings have been positive. It gets folks to actually more consistently do the thing. And it also shows differences in how long they show up for consultation on the things. If you didn't get BASIS, you were much more likely to not show up for your consultation calls on trauma-focused CBT or one of these other strategies, which is really important to try to avoid. All right, last example, intervention level. What do I got? I got 2 minutes. We can do this. So let's hit the intervention level. Remember, we're hitting all the levels here. We're looking at the inner setting, organizations or schools, individuals, so we can develop BASIS. What about the interventions themselves? Well, we know that our strategies, whether they're interventions or implementation strategies, can be better designed. And this is really important. It turns out that design of a program really drives the outcomes of whether it gets done or not. Variability in mental health therapists' implementation intentions is accounted for, the majority of it is accounted for how good the intervention is for them. There's all sorts of evidence. Despite this, the innovation characteristics are an underemphasized, maybe even forgotten domain in implementation science. So what we're really looking at now is usability tests, stress tests of psychosocial interventions. So we are right now looking at 10 social emotional learning programs. Has anyone here heard of Second Step or Ruler, Character Strong? They're all in there. The developers volunteered all of their materials for us to walk through a set of exercises with teachers as well as students that is asking, how efficient is this program actually likely to be for you? How effective is it? How many errors do you make? So our poor staff are running folks kids and teachers through scenarios from those 10 SEL programs. And we're asking whether or not the intervention usability is associated with perceptual implementation outcomes as well as behavioral implementation outcomes, like actually getting it done out there. And ultimately, we're hoping that and expecting that it's related to the ultimate outcomes we're looking for, which is if SEL gets done well, it actually really improves kids' coping skills and their academics. So upstream, there's a lot to be accounted for by the intervention. And we're going to test out the question of whether or not, of how much the intervention's usability is actually related to those implementation and ultimate outcomes. Here is the usability project, which is an acronym. The usability, so here's an acronym where the first letter is the acronym. The usability of social, emotional, and behavioral interventions, links to implementation and translation to youth outcomes. So it really should be usability-yo, but it is usability. So this is something that was funded by the Institute of Education Sciences. And again, it's based on the idea that intervention usability is really critical. I think I will skip through the details here and conclude with a couple of points from this example of usability. Our goal for usability is to generate generalizable design solutions. So what do we find are actually the barriers with respect to usability of these SEL programs? The cool thing is our Alacrity Center has now done this with 10 plus social, emotional, and behavioral interventions out there for clinics, for primary care, for schools. And they have cataloged and characterized all of the usability problems that they have found in all of these different kinds of interventions, which is really neat. And they're finding that this is the biggest one. Too complex, cognitively overwhelming. Followed by time required exceeding time available, incompatibility with preferences, and so forth. And so we're accumulating all these lessons learned by using these consistent methods, and then asking what are the best heuristics for addressing these common usability problems. In our usability project, what we're really looking forward to is bringing all the data together with the developers for all 10 of those programs and having a big design hackathon where there's a no harm, no foul. What are we finding are the problems with your programs that might not be barriers to them actually getting used out there? And what are the design solutions that either you individually or this entire group of folks, again, it's all about relationships, folks. We're bringing them together and we're hoping that we're going to have like a long-term learning community of these SEL developers around usability. So let's just return to our main points. School mental health is essential. We got robust evidence for all sorts of stuff. Got to be asking, how do we look at the determinants at all of those different levels? How do we consider design of both the strategies we'll use at those levels and the interventions themselves? And I didn't get to my outer setting examples. The big one being that we are asking, as Shannon did, how do we get paraprofessionals who are non-licensed clinicians in our schools doing evidence-based practices? And what we're learning is those kinds of individuals. So, a big determinant or barrier is that the context doesn't actually fit the programs we have. We are able to employ paraprofessionals and aides in our schools a lot easier than we can bring in mental health clinicians. And we're finding that our paraprofessionals can get way more done. They can provide tier 2 services that really resemble mental health interventions. Just don't call it that in Utah, which is one of our states. And they can do this at such a scale that is so much bigger than when you bring in mental health clinicians into schools. They don't have those productivity requirements that their home clinic is making them have, which keeps them seeing the same kid over and over again. We teach them brief interventions. And what we found is that they are getting outcomes on the same scales as we used for our licensed clinicians doing EBPs as the licensed clinicians are. And kids like it better. For whatever reason, the paraprofessionals are viewed as way more relatable, and their experience of students is way more satisfying. So that's my policy point. And with that, I will say thanks very much, and feel free to email me at any time with questions or thoughts. And we can ask questions now.
Hey, excuse me. Thanks a lot. Really great talk. The CWIS where you're mapping out kind of all the implementation strategies, that seems to be a time-intensive process in and of itself. And I was struck with the biggest barrier being we don't have enough time. So yeah. I'm curious if you've run into any sort of conflict there. I mean, we see this in our own implementations where, you know, sometimes we feel the need to take it slow to plan things out, but you know, this contract expires Tuesday and we have to get all the money spent, so let's go.
Well, I think the thing about the CWIS is that we're not asking a lot of professionals out in the field. The vast majority of those steps are involving the developers. So you could kind of say, if you're going to spend 2-3 years on an efficacy trial, what if you spend 2 or 3 months actually doing this process of asking, now that we've learned that this thing works, what might be the ways we make sure it gets done out there? You're really only bringing in folks for whom they're not being paid to do this development and research at some very strategic points in that process. Most of those identification of tasks, rating their likelihood of being the source of errors and so forth, that's going to be the folks who are developing the program itself. So I totally hear you. What's really interesting is even intervention developers say, well, we don't really have time for all of that. And yet they will spend $2 million federal dollars on doing the efficacy trial with 100 kids so they can get on a registry, right? How about getting it out there for the world? Let's now do some of these steps to bring human-centered design to the quest. Yeah, but I hear you. It does feel kind of wonky and involved, and it is. But again, it seems like it's the right people who we want to burden with that time. Yeah.
This was fantastic. Thank you so much.
Thanks.
I love the idea of bringing the SEL program developers together and seeing how can we do all this and implement better on a broader scale. And maybe this is just me being cynical, but I'm surprised that all of them share their materials, and I wonder if they might even view each other as competitors.
Yeah.
So the question is, I'd love to learn more about that process and how do you motivate them to work together in a way that works?
What an interesting question. I will not name names. But let's just say that it was a minority, but there were developers who clearly were not invested in this idea. And it was interesting to hear their rationale, even though they provided the letter of support when we put in the grant, when it came time to actually do it, the different ways in which they begged off of the project. But the vast majority, I think that's really one prominent program that will not be named. The other 9, they were all in. And it's just been we're only about halfway through just the testing. I haven't even really done the analyses, but it is really fascinating to hear and watch some of the testing sessions and see just how different the burden is. On our team developing the scenarios, there could be a direct relationship we'll find in how hard was it to put the scenarios together for the testing sessions and how usable the program winds up being after having done this systematic process. Another thing that is really interesting is that the way we're going to get to the outcomes is we're doing usability sessions. That's kind of aim 1. Aim 2 is we're going out there into the real world and administering surveys and doing interviews with users of the programs, separate from the testing sessions, so that we can associate the usability tests data with the implementation and student outcomes data. And it's really interesting to see how quickly certain interventions, certain of the SEL programs were able to find folks who were willing to do the surveys about it, and which ones had a really hard time. I have a hypothesis that when they put the calls out to the schools, the ones that came flooding in with, we'll do the survey, that might be a proxy for how usable the programs are. The ones who are willing to do this are the ones who are like, oh yeah, I want to talk about how great it's been. But we will see. But it's been a really interesting project. Yeah, so stay tuned. Yeah.
Thank you, Eric. That was a great talk. And I have a follow-up question on the usability project. I was curious, with all the strategies to make the programs more usable, what are your thoughts on effectiveness impact?
Well, we've seen that be something that affects, the literature is very clear that variation in program content and just programs themselves really affects intent to implement and then ultimate use, right? I am very interested, I think that even if we find, as I very strongly hypothesize, that usability is going to affect ease of use, adoption, sustainment, the implementation outcomes, it's going to be that extra link in the causal logic chain to get to student outcomes that is going to be tough to get at just because of how many factors affect student outcomes. But I really do hypothesize that the implementation outcomes are going to be pretty well related. It's just kind of for us a question of power. Because you got 10 programs, maybe 20 schools rating each program. It's going to be interesting to see where the signal is in all of that noise. There's a lot of noise in education research, so we'll see. Again, another stand by. Yeah, anything else? Yeah.
Hi. Thank you for this talk. It was really, really great to learn more about your work. So I work within the National Institute for Student Success here at Georgia State, and we've been sort of trying to scale evidence-based practices to different institutions across the U.S. focused on improving graduation, retention outcomes, and post-secondary education.
Nice.
One of the things that we try to do is customize the recommendations and the evidence-based practices to each institution based on a diagnostic process. And I think one of the challenges that come up time and time again is how do we maintain fidelity while also having customization? Right. And as you mentioned earlier in your talk, it's so important to do these things with fidelity to reach that effectiveness. So my question for you is, how do you toe that line between customization and fidelity? And are there certain lines to draw in the sand?
Oh, man. There are so many wonky things I could say, right? So one is there is no implementation without adaptation. We know that. Adaptation happens with every program. It is not an either or, right? The second thing is that we think in implementation science that there's something that can be discerned that is a core characteristic, and then there's the adaptable periphery, right? So the easy answer is you got to keep the core components that have been found to lead to positive outcomes, while the adaptation can be readily done with the adaptable periphery. By its name, it's adaptable. But what is a core component and what's something that's optional or adaptable is something that is very difficult to discern. So I think that as with so many things, those are the kinds of decisions that ideally are made by blending the actual available evidence with the perspectives of the actual intended users and trying to get to a happy medium. There's unfortunately no real pat answer. But you have a really great opportunity to potentially learn about the next adaptation that might get done from all of the previous ones, right? So my suggestion would be find some sort of framework or heuristic for kind of capturing the adaptations. There are tools for capturing and characterizing the adaptations that either get done or are proposed. Shannon Wilsey Sturman has one called the FRAME. Am I going to remember that acronym? Something with adaptation in the A. But anyways, it's a framework for adaptation, something and something. But so there's ways in which you might look to the literature both to say how do we study and guide adaptation, as well as then capture what you're learning yourself by kind of bringing a community of practice together around that. But yeah, hit me up with an email and I'll send you some resources. Yeah.
Hi. Yes. So as a former leader in K through 12 education, I can say that your practice is much needed around usability for SEL.
Oh yeah.
Yeah, it's huge.
Ooh, tell me some stories. I want to hear them.
Listen, I got stories for days. But I do want to ask, in terms of the boundaries or confinements in which you kind of scale usability or measure it, do you consider the external factors that are at play? Because, for example, during the implementation where teachers are trying to teach the SEL curriculum, there might be behavior concerns. There might, their incidents happen all the time in classrooms. So was that considered, or is that something that you will look at as you analyze the data?
Wow, what a great thought and question. Let me bring up our little CFR map here, right? So what you're kind of, what you're kind of suggesting is something that's really interesting, which is that even when we are looking at these individual levels, I'll just go here. So even if we're looking at, for example, we're testing the characteristics of the intervention, but like you say, all of these things interact, right? So like you say, it could very well be the school climate, or the behavior of the students. It could be the level of resources that the students do or don't have, or that the school does or doesn't have, that interacts with the intervention characteristics like usability. So your point is a really good one, which is, are we going to have the ability to, at some point, because I don't think our study now is going to be able to do it. It's like a little bit too complicated already as it is, so we have to kind of keep all these things in silos, just like these do have lines around them. It's not all kind of gray areas where we recognize everything's interacting. But I think that ultimately it would be a really important thing to consider these other kinds of factors as covariates and influences of our assessment of usability. I think that there's a lot of great work getting done out there with virtual classrooms that might be a way to kind of get at that a little bit. So is there some way in which we could evaluate the usability of a program where we set up the virtual classroom to be like, maybe disruptive students versus really, kind of well-behaved students or something like that to test out your question. But as it is now, it's going to be something that probably be more future research and a need. I like that, though.